My name is Nancy Poole, and it's my pleasure to be your moderator today. I'm the prevention lead for the CanFASD Research Network and the director of the Center of Excellence for Women's Health. It's great that these two organizations that I work with are co-sponsoring this webinar, and for all of us to be thinking about how policy as well as service provision and health promotion is important to our work. Before I turn to our presenters today, I want to acknowledge the First Nations, Inuit, and Métis as the first inhabitants and traditional custodians of the land in which we all live and work and play on. An important step in reconciliation is the acknowledgement of traditional treaty lands and recognition for the people of the territory. The Canada FASD Research Network recognizes the historical significance and contributions of Indigenous peoples and their cultures and understands the important role that the Indigenous community plays today and in the future. We acknowledge that we live, work, and meet on the traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. In today's webinar, we'll be talking about alcohol policy and FASD. Efforts to prevent FASD are linked to the alcohol regulatory policy field, as well as the health and child welfare and mental health, substance use, justice, housing, and social policy sectors. And today we'll explore what alcohol policy is indicating, including nationwide efforts to evaluate the uptake of evidence-based alcohol policies at the provincial, territorial, and federal level, and how these policy initiatives can inform future FASD prevention efforts. After today's webinar, we'll have two more webinars. Next Wednesday, please join us for a webinar on Canada's guidance on alcohol and health, the knowledge mobilization and uptake 2 years later. And in that webinar, we'll walk through Canada's guidance, discuss how alcohol guidelines can bring attention to alcohol use, and include a discussion of the implications for FASD prevention. The presenters will share an update on knowledge mobilization efforts, including regional initiatives that clinicians and the public can use to guide drinking throughout their lives and the perinatal period. And our final webinar will be on March 5th, where we'll focus on provincially focused efforts and how they've been made to promote FASD prevention through collaborative alcohol policy strategies, examples from 2 provinces. And more details, including the confirmed speakers on that, will be coming in the next week. So our first presenter is Elizabeth Farku, and Elizabeth is a research assistant at the Canadian Institute for Substance Use Research and a 4th-year medical student at the Mayo Clinic Alex School of Medicine. She received her Bachelor of Science with high distinction from Cornell University in 2021. And she's contributed to a review of the effect of alcohol policies on suicide, an educational curriculum on alcohol and cancer for middle school students across Canada, and most recently to the Canadian Alcohol Policy Evaluation Project that we'll hear about today. She's also contributed to the World Health Organization's Global Information System on Alcohol and Health, and her interests include preventative medicine and health policy advocacy. Welcome, Elizabeth. So interesting, your work. Our second presenter is Lindsay Wolfson, and Lindsay is the manager at the Center of Excellence for Women's Health and a Master of Social Work student at Wilfrid Laurier University. She holds a Master of Public Health, Social Inequities, and Health from Simon Fraser University. And she's responsible for research and collaboration on projects related to Indigenous health and wellness, fetal alcohol spectrum disorder prevention, and the integration of gender, trauma, culture, and equity-informed approaches into policy research and practice with us at the Center of Excellence for Women's Health. So so great to hear from you, Lindsay. So we'll start by turning to Elizabeth. Over to you.
Thank you so much, Dr. Poole. So today I'm going to be talking about alcohol policy in Canada, and specifically findings from the Canadian Alcohol Policy Evaluation Project, which we call CAPE for short. Next slide. We would like to thank the funders and supporters of the Canadian Alcohol Policy Evaluation Project. I do want to point out that the views and opinions expressed as part of this presentation are those of the CAPE team and don't necessarily represent those of our funders or other organizations that we have acknowledged. Next slide. So going over presentation objectives, we hope that by the end of this session, participants will be able to describe alcohol consumption, costs, and harms in Canada, describe evidence-based alcohol policies that are proven to reduce harm from alcohol use, and identify some challenges and opportunities to improve alcohol policies in Canada. Next slide. So I did want to start with a little bit of a trivia question. How many standard drinks per person aged 15 and older are consumed in Canada each year? And if we could start the poll, that would be great. So go ahead and give it your best guess. All right, we can probably close the poll. Great. Okay, next slide. So I think quite a few people actually got this right. So it's actually 487 standard drinks per person, which amounts to about just over 9 standard drinks per week. But it is important to note that this is actually a significant underestimate because the calculation actually includes the entire population. So that would include non-drinkers, which we now estimate is roughly a third of the population. So this number is actually staggering on its own. But when you consider the fact that non-drinkers are included in this statistic, it's even more staggering. So Canada drinks significantly is the message here. So in talking a little bit about alcohol harms, so why is alcohol consumption a population health issue? We know that in 2020, over 17,000 deaths were attributable to alcohol use in Canada. And we know that alcohol contributes to many more cases of chronic disease, trauma, injury, violence, ER and hospital admissions, social problems. The list really goes on. And we know that the impact is experienced not only by the highest risk drinkers, but also many others, including non-drinkers. And in all provinces and territories, the costs of alcohol to health, justice, and workplace settings actually exceed the revenue from alcohol sales. And so looking to the right-hand side of the screen here, we can see that alcohol revenues totaled about 13 billion, while alcohol harm costs totaled roughly 20 billion, for a total alcohol deficit of over $6 billion. So contrary to popular belief, alcohol actually costs the government more than the revenue generated. And when calculated per standard drink, that actually estimates at about 38 cents per drink. So it's quite a significant cost. Next slide. Just going over some alcohol health harms. Alcohol is a class 1 carcinogen that's linked to at least 7 cancer types and contributes to about 7,000 cancer cases and over 3,000 cancer deaths every year in Canada. Fetal alcohol spectrum disorder, which is the reason we're all here today, is a lifelong disability from exposure to alcohol in the womb, and it impacts about 4% of the Canadian population, which is significant. I always think about it as 1 in 25, which is a really large number. Next slide. So how can alcohol-caused harms be reduced? That is the question. Next slide. Public policies are a really important structural determinant of health that can change alcohol environments and can really yield population-level reductions in alcohol use, harms, and costs. We know that evidence-based alcohol policies really have an essential role in countering the alcohol-related commercial determinants of health. So that's things like lobbying activities, marketing to vulnerable populations, alcohol industry interference in policymaking. So these policy actions can be implemented at the federal level, the provincial or territorial level, and as well as the municipal level. And they include things like increasing alcohol prices, limiting physical availability of alcohol, policies to deter alcohol-impaired driving, and several others that we'll talk about during today's session. All levels of government in Canada actually control elements related to the distribution, sale, and consumption of alcohol in different ways. And they can really complement each other by working together to create a comprehensive regulatory framework that really balances the local needs with the wider provincial and federal objectives. I do just want to also touch briefly on the fact that, alcohol and social determinants of health are really intertwined. The relationship between inequities and alcohol consumption, as well as alcohol-related harms, is complex and it's influenced by many factors. But we do know that poorer populations experience disproportionately higher levels of alcohol attributable harm, despite actually drinking less. And this is something known as the harm paradox. Next slide. So what is the Canadian Alcohol Policy Evaluation? So CAPE is an ongoing research project that really provides rigorous assessments of the existence of evidence-based alcohol policies at the provincial, territorial level, and also the federal level of Canada. We don't assess the municipal level. We provide evidence-based, up-to-date information, systematic policy comparisons between jurisdictions, and really also provide some guidance to policymakers that are seeking to reduce alcohol-caused harms. Our assessment actually includes 11 domains at the provincial and territorial level, which are shown here on the right-hand side, and also 10 at the federal level. And these domains are ranked according to their impact and scope. So for example, here we see that pricing and taxation is at the top, and that's because policies like minimum unit pricing, alcohol sales taxes, and retail markups are some of the most effective strategies that can reach a large proportion of the population and really have a significant impact on reducing consumption and alcohol harms. And these really are synergistic. We do split them into domains, but ultimately they all form part of a comprehensive and synergistic approach to preventing and reducing various types of alcohol harms in Canada. Next slide. So how is CAPE actually conducted? So we follow a very rigorous methodological process, which involves developing and applying a scoring rubric in order to produce scores. The rubric is a template that details our policy indicators for which we collect and score data. These indicators are really considered the best practice, and they're grouped, as I mentioned before, into these policy domains. So pricing and taxation, for example, is a policy domain. The domains are based on broad policy areas with well-established evidence showing positive impacts for public health. So the key message here is this is all really evidence-based. We rigorously look into the literature and base our recommendations and rubrics off of the latest evidence. It is important to note that our scores are not directly comparable across time. So we've had 3 iterations of CAPE. So CAPE 3 and 2 are not directly comparable, but they do reflect the overall direction of government approaches to alcohol policy in Canada. I do want to mention as well a comprehensive description of our methodology and summary of our results is available on our website. And so today really is an overview, but if you are interested in the specifics, please do check that out. So this slide really highlights policy indicators at both the federal and provincial and territorial levels. Again, full details available on our website for this. At the provincial and territorial level, we can start with pricing and taxation. We know that raising alcohol prices is a really effective population level strategy to reduce harms. And particularly when taxation is adjusted for inflation, it helps maintain those prices so they don't deteriorate over time with inflation. At the provincial and territorial level, these include things like minimum pricing, alcohol-specific sales taxes, and retail markups. And federally, this includes things like excise taxes, sales taxes, and minimum pricing in some federally controlled areas. Moving on to our second highest ranked domain, which is physical availability. This refers to how accessible alcohol is, and it includes things like outlet density. So outlets meaning things like liquor stores or bars, trading hours of these outlets, and delivery services. We know that limiting availability significantly reduces consumption and harms. And we know that things like outlet regulations, trading hours, and controls on alcohol imports at the federal level are very important in this domain. The final domain I'll talk about today, just for the sake of time, is alcohol control systems. So these range from government monopolies, where the government really has full control over alcohol sales, to full privatization. We know that privatization is not good for public health. It increases outlet density, so that is the number of outlets in a given area. It extends trading hours and it lowers prices. Those are all things that contribute to increased consumption and harms. And so at the provincial and territorial level, these include we really assess, whether government has regulation over alcohol sales, wholesaler requirements, and retail practices. While at the federal level, this actually assesses things like an Alcohol Act, which Canada does not have currently, and also whether they incentivize provinces and territories to maintain control over their distribution and sale of alcohol. Next slide. So how is the government performing? Well, the summary is not well. This is the federal assessment. And overall, the score was 37% across the 10 policy domains. And so really the federal government's failing to implement the best evidence-based policies to reduce alcohol harms. I do want to point out too, it's very interesting that we found this, because if you look at the top 3 rated domains, they all received failing grades, while the lowest rated domain, for example, monitoring and reporting, as well as screening and treatment interventions, received some of the highest scores. So this really tells us that there's a need for a priority shift towards the policies that are most evidence-based, because Canada is actually doing fairly well in the lowest ranked domain, which is monitoring and reporting, but things like pricing and taxation, which is the most effective alcohol policy, received a failing grade. So I think it really shows that we need a priority shift. Next slide. So these are our policy recommendations at the federal level. So for the federal level, we really recommend increasing federal sales taxes on alcohol, indexing them to inflation, as I mentioned, and basing them on ethanol content. We actually know that when taxes or prices are based on the amount of ethanol in the beverage, it actually incentivizes people to consume lower ethanol content beverages, which is better for public health. And finally, incentivizing minimum pricing at the provincial and territorial level. In addition, we recommended updating and expanding the CRTC code to apply to all advertisers and media types. The CRTC code, for those who aren't familiar, this is really a code that's at the federal level that regulates alcohol advertising. Unfortunately, however, it only regulates broadcast and television advertising. So things like social media, the code actually doesn't apply to that. And so we recommended that it be expanded to include social media and other digital forms of advertising. We also recommended implementing a health-focused surveillance and enforcement of alcohol marketing violations. Currently, the system relies heavily on industry self-regulation, which evidence tells us does not work. We also recommended requiring labeling on alcohol containers that have information regarding standard drinks, serving size, health information, such as a pregnancy warning, as well as a cancer warning. We also recommended formally endorsing Canada's guidance on alcohol and health, providing incentives for provincial and territorial governments to retain those government alcohol monopolies, implementing a federal alcohol act that's supported by an independent alcohol strategy so that we can really have a national framework for addressing alcohol harm. And then finally, setting a federal minimum legal drinking age to 21. There's some really good evidence from the United States, which has a federal age of 21 that actually it really reduces the harms from alcohol use, specifically from traffic accidents. Next slide. So these are the scores for the provincial and territorial governments. We can see that the highest scores were in Manitoba, Quebec, Newfoundland and Labrador, and Ontario, but they were all actually around 40%. So still very bad, but just highlighting the folks who are leading the way here. The overall average score was 37%. We can take a look as well at the average scores by policy domain. We can see that the highest average scores were for screening and treatment interventions and monitoring and reporting. So again, domains which do have an impact, but are not as effective as things like pricing and taxation, for example. I do want to briefly mention that screening and treatment interventions, the indicators that we assessed were really whether the services existed, not the quality or quantity of those services. The lowest score across jurisdictions was actually health and safety messaging. And so it's just important to note that as well. And again, reflecting back on those federal results as well, we can see that the highest impact domains are scoring the worst and the lowest impact domains are scoring the best. So really a need for a priority shift. Next slide. I do want to briefly talk about the best existing policy score. So this is really what score could be achieved by any jurisdiction if they were to implement all the best policies that are currently in place somewhere in Canada. So, our rubric is the gold standard, the absolute best ideal situation. But we know that sometimes it can be not practical to have 100%, for example. And so we looked at what policies were in place somewhere else in Canada. And when you actually took all of those best existing policies, the score would increase to an 80%, which is an A minus. So really, this tells us that best practice alcohol policies are achievable, they are feasible, and we really just need to look around Canada to see who's leading the way in various domains and really follow their lead. Next slide. I do want to briefly touch on some of the policy recommendations for provincial and territorial governments. So for pricing and taxation, we recommend that there are minimum prices per standard drink as listed on the slide here, and that also there are alcohol-specific sales taxes according to our limits in our rubric. We also recommended in terms of physical availability that there were limits on the density of alcohol outlets and that also trading hours were regulated according to the hours listed on the slide here. We also really wanted to highlight that it should be that there's no exceptions or extensions. Frequently, there's trading hours or outlet densities, but for whatever reason, people are able to get a free pass, and it's important that this regulation applies across the board. In terms of control system, we recommended government-owned and operated retail networks for off-premise outlets, reporting to a ministry with a mandate to protect health and safety. Frequently, governments were really the government ministries that were controlling the aspects related to physical availability, for example, were actually ministries of finance and not ministries of health and safety. And so we did feel that was important as well. In addition, we recommended comprehensive restrictions on placement, quantity, and the content of ads, as well as sponsorship, and that this would apply to all media types and advertisers, and also that there would be an independent pre-screening, independent meaning independent of the alcohol industry, because again, we know that self-regulation does not work, but that's the current system in Canada. We also did touch again on the warning label issue, and finally, endorsing Canada's guidance on alcohol and health was another recommendation. Next slide. So in terms of health and safety messaging, I think alcohol labeling is particularly important when we're thinking about FASD. We actually know that alcohol beverage labeling has been a particular topic of interest as a tool for raising awareness of alcohol's contribution to cancer and chronic disease, which is a link that's not well known among people in Canada. So currently, there's actually no information on standard drinks per container. So there is a percent alcohol by volume, but it actually requires some calculation for someone to require how many standard drinks are in the container. The federal government has not acted currently upon the recommendation of Canada's guidance on alcohol and health, which called for mandatory labeling of alcoholic beverages. And there is a bill in the Senate currently that's awaiting consideration, which is an act to amend the Food and Drugs Act, which would require warning labels on alcoholic beverage containers. But that is a bit of a tenuous process. And so we are hopeful, but something to be aware of. And I also do want to mention that Northwest Territories and Yukon have chosen to require labels with health risk messages. So those are some of the best practice policy leaders when we're thinking about alcohol labeling. Next slide. In terms of health and safety messaging, on-site signage can be important as well. I think particularly when we're thinking about FASD. Alberta, which is on the left here, this sign is from Alberta. It's actually the only province or territory to require both a no minors sign at the front of the door and also require this FASD warning on all on-premise licensed establishments. Ontario, this is on the right here, that's Ontario's warning sign. They do require that a warning sign on alcohol and pregnancy risks be displayed where alcohol is sold at all premises. So if you go into any restaurant that serves alcohol, for example, you should see this sign. Hopefully in all locations that is the case because that is the regulation. Next slide. So just some key takeaways. Alcohol is really treated differently than other substances, both legally, culturally, and in public discourse, despite large health, social, and economic harms. A statistic I like to share with people is that alcohol actually costs more than tobacco and opioids combined, but I'm fairly confident if you ask Canadians, a vast majority would not be aware that alcohol is so harmful as compared to something like tobacco or opioids. We know that alcohol policies are the key modifiable means by which to prevent and reduce harms. And unfortunately, recent trends and policy directions have really headed towards privatization and deregulation. An example of this is in Ontario. There is now alcohol in convenience stores and a huge trend towards privatization. Policy development really lacks meaningful public health input and tends to favor commercial interests. And we know that governments have an important role in alcohol policy, and there are many opportunities for policy action to improve the well-being of people in Canada. And that's really demonstrated by our results and recommendations. Although the scores were not great by any means, there is room for improvement. And again, that best existing policy score, I think, can really give us a lot of hope. Next slide. I do just want to briefly mention we have a ton of resources on our website, so please do check that out if you're interested. We have result summaries for each jurisdiction. We have infographics. We have our rubrics. We have some information on those best practice policy leaders, and we also have information about our methodology and evidence review if you're interested. Next slide. I do also just want to briefly touch on this community of practice that we launched in 2022, led by Tina Price, who is the first author of this paper that we actually just published in the Canadian Journal of Public Health, which really explains what our community of practice is and how it was developed. This is really an opportunity for stakeholders across Canada to come together and learn about alcohol policy. We host webinars, we have a listserv, we have working groups for things like alcohol labeling. And it's a really great way for folks across Canada to come together and brainstorm ideas about how to move forward with alcohol policy in Canada. We do have a link to join that's up on our website, and I would highly encourage anyone who's not a member of our community practice to check that out and consider joining. It's a great way to really engage with folks across Canada and learn more about alcohol policies. And with that, that is the end of the presentation, and thank you so much.
Thank you, Elizabeth. What a lot you gave us to think about, and even some hope, which we sure can use. So lots to think about. I think we'll leave all the questions till the end for now, and we'll so put them in the Q&A section, and we'll turn over to Lindsay.
Thank you so much. And Elizabeth, I have to say, I normally start this presentation without having the background around alcohol policy. So this is a huge joy to have you do such a comprehensive job of talking about what alcohol policy is in the landscape here in Canada. And as we come to the second half of our webinar today, I'll talk a little bit more about how it relates back to FASD and women's and fetal health. And you can see here, this is based off of a paper that Nancy and I published a few years back now, all about how supportive alcohol policy is a key element of fetal alcohol spectrum disorder prevention. And so I'll talk a little bit about our findings, and I'll really take what Elizabeth shared about what alcohol policy is and bring us into the conversation around fetal alcohol spectrum disorder prevention. So as Elizabeth mentioned, we do have these 11 domains that have been identified as we think about alcohol policy in Canada. And not all of these are related to gender or pregnancy. And there are also several domains in which we don't have adequate research. So if I think, for instance, about physical availability, which is a really important domain as we're thinking about alcohol policy and evaluation, we really only have one study or two studies that I can think of that narrow the scope to think about how physical availability influences prenatal alcohol use and FASD. But with that being said, it is certainly all of these areas are really important, and I will be focusing this presentation on the few that are most relevant as we bring in the conversation about pregnancy. And as Nancy said, it's not just how we think about alcohol policy, but also about how we are linking the health, child welfare, mental health, substance use, justice, housing, and social policy sectors. And so all of these are kept in mind as we're thinking about alcohol policy and FASD prevention. For those that are new to conversations around FASD, I just wanted to share this model that we have here in Canada. And when we're thinking about preventing FASD, we're not just thinking about preventing alcohol use, but we're also thinking about these social and structural determinants that influence alcohol use. Here in Canada, we have this four-part model of prevention that includes a continuum of multi-sectoral efforts. And you can see here that supportive alcohol and child welfare policy are at the center of these four mutually reinforcing levels of prevention. And we know that evidence-based alcohol policies, when widely implemented, have considerable potential to reduce the harms of alcohol use. And this is because they really determine the availability of alcohol and other aspects of our environment in which decisions about drinking are made. And so these policies, particularly when they relate to women's and maternal health, should be in alignment with child welfare policies and the other policy sectors I mentioned to ensure that care is wrapped around a parent-child unit. But of course, these are all interconnected issues. And so, as I talk today, I'll sort of break down alcohol policy not in the 11 domains that Elizabeth mentioned, but rather in how we think about them in terms of this four-part model of prevention. And just to give a little bit of scope before I jump into those four levels, the paper in which I'm presenting on that really we started thinking about alcohol policy was based off of this larger review that was published a few years back in 2022 that really talked about the state of the literature on FASD prevention over a 5-year period. And so a little bit of what I'll speak to is from this larger review article, and then I'll also be speaking specifically to the policy piece. So when we're thinking about level 1 prevention, we're largely thinking about health and safety messaging. We are talking about broad awareness raising and health promotion efforts, and also community development. And we know from the research that proximity to alcohol serving establishments, including liquor stores, increases the risk of alcohol use during pregnancy. In Canada, as Elizabeth mentioned, we have different ways of level 1 prevention being enacted. So, for instance, in the Yukon and Northwest Territories, we have warning labels on alcohol beverages. In Ontario, we have Sandy's Law, which is a mandated sign that Elizabeth showed. Um, in BC, we see things like alcohol and pregnancy warning signage that was created in 2014 with the Center of Excellence for Women's Health, and that gets updated and promoted every single year during FASD Awareness Month in September. And then, of course, we have the Dry 9 campaign, which Elizabeth also showed from Alberta. And we can see that all of these have quite varied effects, and they're also done in different ways depending on the jurisdiction. But when we think about this first part, what's being done in Yukon or the Northwest Territories, for instance, we can think about warning labels as this low-cost, population-level prevention and health promotion approach. And we recognize that there is mixed evidence. So in terms of FASD prevention, we see that research on pregnancy warning labels have been associated with a reduction of alcohol sales and heavy binge drinking during pregnancy. And we saw that in a couple Canadian studies, changing information, so having rotating alcohol warning labels, helped, and also adding standard drink sizes, which Elizabeth mentioned, helped us better understand the guidelines and help people estimate consumption. We also see research which emphasizes the importance of color, size, location. And I put up this example from Germany. I know it's a little bit blurry, but it's so different than a lot of the warning labels we see because so many warning labels we see have sort of this X that goes between people. And this is, a more empowering approach that we can imagine of somebody saying no to a beverage, which I know can be incredibly hard in the society we live in. We also see research that shows how warning labels can be quite effective when they're in combination with other prevention strategies. So when we're also thinking about the posters, the informational pamphlets, and engagement with health and social service providers. So as we move into sort of the levels 2 through 4 of our prevention model. These are a couple other examples of level 1 prevention. So they're more similar to what Elizabeth showed, these point of sale warning signs. So we have that one at the top I mentioned from BC Liquor. We also have examples from the Yukon. We have the Yukon FASD Interagency Advisory, which says, let's meet at the coffee bar. Or the example from the Saskatchewan Prevention Institute that says, this is why. And I think what's really great about these is that they are able to be so contextual. So we're able to think about the population in which we're serving and what's appropriate. And so, for example, if we're thinking about that poster from the Yukon, when another territory was interested in using it, they realized actually we don't have coffee shops available. This is not necessarily the poster for us. And so we can share strategies and yet contextualize it to the population that we're serving. And we do see in the research that these point of sale warning signs can be quite effective. We have one study that showed that they can lead to a 11% decrease in odds of alcohol use in pregnancy and a 16.6% decrease in odds of first-time mothers using alcohol in pregnancy. So that's quite a big reduction. And beyond this, we do see great policies that focus um, on community-based strategies that are really focused on community action and policy action that determine the availability of alcohol. In our second level of prevention, we talk a lot about brief intervention and support by health and social service providers. And we'll dive in a little bit more to this level of prevention next week as we talk about Canada's guidance on alcohol and health and the implications of the guidance on things like discussions during the preconception period or during pregnancy with health and social service providers. But in terms of what we see, this is the area where we see most of the literature published because we're thinking not only about these guidelines about alcohol and health, but also the uptake of these guidelines. And there are many countries that have low risk or dietary lifestyle guidelines that include recommendations about alcohol use in pregnancy. But one of our biggest challenges is the uptake of these guidelines. And that's why we really wanted to make sure that we did have a webinar that specifically focused on what that can look like. Right now, we see most of the research is looking at guidelines from other countries and what the uptake has looked like. And so, for example, we have research from the UK that looked at the 2016 Chief Medical Officer's Guidelines, which really recommended abstention from alcohol use during pregnancy. But follow-up research with midwives in the UK showed that only 58% were aware of the updated guidance and 19% continued to use previous guidance. And so we really have to think about what knowledge mobilization looks like. We also see the implications and the impacts of providers' beliefs and perceptions on the uptake. So, for example, from the US, we see that individual level characteristics like age, education level, race, type of insurance, these were all associated with increased odds of screening. And we also see a lot of structural considerations. So, in states where laws mandated providers to test for substance use in pregnancy, there was a higher prevalence of screening. But in states where there were laws that were designating prenatal substance use to be considered child abuse or neglect, that rates of screening were lower. And so we see this time and time again, the policies that are maybe intended to support and really support these conversations around alcohol and health can perpetuate beliefs and reduce access for those that consume alcohol in pregnancy. And so we have to think about these as we are developing guidelines and encouraging these conversations as well. In terms of our level 3 and level 4, these are our levels that think about the provision of a holistic support for women's substance use and other health and social concerns during pregnancy and the postpartum period. And we saw that between 2015 and 2021, only 3 articles described substance use policies and treatment access. And again, all of these studies were published in the US. And so we could see that state level prenatal substance use policies and substance use treatment admissions hindered depending on how substance use during pregnancy was criminalized. So, in states where substance use was criminalized during pregnancy, there was a decline of substance use treatment admissions. And in states where we thought of these multi-pronged policies that were inclusive of alcohol, but also other sectors like health, like justice, example, we saw that treatment and support services, clinician reporting requirements, criminal justice initiatives, we saw these increases of substance use treatment, indicating this really large importance of having cross-sectoral policies. And for some women, a mandated substance use treatment was seen as a means of promoting safety and connection, especially in the context of trauma, abuse, neglect, and familial substance use. And so it's nice to see in Canada that this is one of our areas where we're doing marginally better because it certainly has an importance and impact on women's lives and their health. As we think about, that last level, I said that most of the research was in the States, and certainly that's the case as we continue to think about legislation. What the studies that we have at least have been conducted exclusively in the States. And it's really challenging because of the shifting and increasingly punitive policy environment. A lot of the policies that are around alcohol and pregnancy really also restrict women's reproductive autonomy, and they have been shown to cause this delay or avoidance in prenatal care or substance use treatment. And we see that these punitive approaches that control or report women's behavior and prompt child removal, but we also do see supportive policies, and we can see the complications. So punitive policies can lead to outcomes like low birth weight, premature birth, but also we might see a lower odds of binge or heavy drinking, and then flipping back, decreased in late entry to prenatal care. And so there's a lot that we're weighing here. Where conversely, if we see supportive alcohol policies, we might see increased odds of alcohol use and better prenatal care utilization. And it's really tricky because if we think about, these studies that are looking at the odds of alcohol use, we also have to consider that this might also be just the climate of reporting, that women might feel safer to talk about alcohol use in some contexts and not in others, depending on the policy climate. What's most important as we think about this increasingly punitive policy environment is that these policies, especially as they relate to substance use in pregnancy, are often lacking the grounding in evidence. And so that's why we're so lucky to be here, where we do have such a large evidence base for what alcohol policies can look like. So I've described some of the ways in which alcohol and pregnancy policies can have beneficial effects, despite the increasingly punitive landscape that we're in. And we really need to consider what this public health approach could look like, and how we can address these concerns like birth weight, increased preterm birth, and decrease in accessing prenatal care. And it's why we need to continue to advocate for supportive alcohol policies as we move forward. And so some of the ways that we can do that include these foci: thinking about stigma reduction, having policies that are gender informed, evidence based, they're attentive to women's and fetal health, and they promote all of these areas here. And if we're doing so, we're able to think about, sex and gender, and have policies that recognize difference in how females metabolize alcohol, but also the environmental factors that influence women's alcohol use. And we can think about stigma reduction. And for those that have seen me present before, I always talk about stigma. And part of it is because the policy discourse and the landscape in which we're in, is characterized by misinformation about what's safe to use during alcohol. And the reality is there's no known safe amount. And so when we think about what's safe and what's not, we often see this prejudicial focus that targets Black, Indigenous, and women of color And so if we create policies that and subsequently focus on implementations that where we're thinking about stigma and we're thinking about evidence, we are able to better promote and have discussions around alcohol use in pregnancy. And so I hope that we're able to shift our policy environment here so we were able to attend to alcohol legislation, promote treatment and appropriate referral pathways, think about cultural diversity, collaboration, and address the social and structural determinants of health, because these are all seen as components of developing and implementing FASD prevention policies that could be crucial in dismantling stigma and supporting women's health and alcohol use in pregnancy.
Well, a big thank you to our presenters today. And I'd like to thank everyone for joining us and hope you will join us in future webinars. Our next webinar is February 12th and is part 2 of this series titled Canada's Guidance on Alcohol and Health, Knowledge Mobilization and Uptake 2 years later. So to get more information on CanFASD and to stay in touch with respect to all the upcoming webinars, please check out the website at www.canfast.ca or follow us on social media channels to find all the resources and the CAPE ones as well. So finally, and most excitedly, we hope to see you at the 2025 Canada FASD Conference, which is happening this October in Toronto, and details are on the website. So thanks, everyone.